Good evening. My name is Jerneja Vidmar. I'm coming from Maribor, University Medical Centre, where I work at the Department of Plastic and Reconstructive Surgery. Tonight, I will talk about our experience with interpositional arthroplasty with RegJoint implant in patients with thumb carpometacarpal joint osteoarthritis. As we know, RegJoint is an implant made of polylactite. It is a small joint spacer used in hands and feet. It's porous, which enables soft tissue ingrowth, and it comes in the form of a disc. It's bioresorbable. In 2 to 3 years. It is resorbed, and water and CO2 are final products. Different sizes are available. Mostly we use number 14 and 16. Our indications in the cases of hand surgery where we use RegJoint are thumb carpometacarpal joint osteoarthritis, mostly Eaton-Littler stages 2 and 3, less stage 4, but still. And then we used it in post-traumatic carpometacarpal joint arthrosis and in STT arthrosis as well. First, I will talk about operative technique we use. Then I will present our retrospective study. We have the biggest, as far as we know, the biggest series of RegJoint implants used in patients with the first carpometacarpal joint osteoarthritis. And then I will show you some of the research we do now in the lab, which was initiated by the results of this retrospective study. A few words on our operative technique. We operate under regional anesthesia. We use dorsal-radial approach. When operating, we have to be careful about the course of radial artery, and we have to be aware of the sensitive branches of the radial nerve. We move tendons of the first dorsal osteofibrous tunnel, and we move them to the radial side, and we move the extensor pollicis longus to the ulnar side. And this is where we then enter the joint. As you can see in the following slide, we perform longitudinal incision of joint capsule. On the left side, you can see distal trapezium. On the right side, slightly, you can see the base of the first metacarpal bone. This is what we see when we open the joint. Sometimes where we have advanced cases, the joint space is almost non-existent, and it makes the operation harder. Then we continue with the resection, usually of the distal part of trapezium, as in this case, sometimes also the base of the first metacarpal bone, or both are resected. In cases of Eaton-Littler stage 4, total trapeziectomy is performed. Then also synovectomy and removal of osteophytes follow. Approximately 4 millimeters of the bone need to be resected so that we get enough space for the spacer. We call this non-press fit technique, which means that the spacer is not tight, it's not compressed. Then we have to choose appropriate size of the implant. As I said before, usually number 14 or 16 in hands. We use stainless steel sizers to decide on the correct size. As is shown on the right side, the spacer should not exceed the level of the joint. Interposition of RegJoint implant follows, as you can see in this photo. We might fixate it with suture to the joint capsule in the depth, but we might also omit this suture. The joint capsule is sutured. We usually also put the K-wire through the base of the first metacarpal bone to the base of the second metacarpal bone, or through the first carpometacarpal bone, joint, so that it is stable. If we go once again through the operative technique, we perform this so-called press fit technique, which means that we cut enough bone so that the implant is not compressed, approximately 4 millimeters. We cut base of the first metacarpal bone and or distal part of trapezium. We remove osteophytes, loose bodies. We perform synovectomy, and then after we choose the correct size of the implant, we put it into the space. We close the capsule, and we also use K-wire to fix the base of the first metacarpal bone, usually to the base of the second metacarpal bone. In cases of Eaton-Littler stage 4, trapeziectomy is performed, total trapeziectomy is performed, and 1 or 2 RegJoints are used. Rehabilitation protocol is as follows: 4 to 5 weeks of immobilization. After that, we remove K-wire, and then physiotherapy and occupational therapy follows. Full recovery is achieved after 6 to 12 months. We have to tell to our patients in advance that they know that it will take some time, but this is when they will then get to the final results. After the operation, when patients came back to us and we took control X-rays, we were quite surprised, because in some cases we noted that there was osteolysis present in the adjacent bones. We didn't know how frequently it will be present, but usually there was no clinical correlation in sense of some swelling, pain, or something. It was just this X-ray that looked a bit weird. This is why we then analyzed the whole series of patients. First, of course, we went to literature. We found out that comparative studies of operative techniques are still limited. Long-term follow-up studies give us information on durability and possible complications. Osteolysis of adjacent bones was reported as an important and frequent drawback in some studies, but there were other studies also that reported on no complications like that. So results of previous studies were quite controversial, and these studies all had much less patients than we already had. This is why we went back to our series of patients. We analyzed what we have. Between November 2014 and June 2024, we operated on 168 cases. In November 2024, in October actually 2024, we invited them for a checkup. And the 116 cases, this means 104 patients, came back quite happy that we invited them. Most of them were really satisfied with the results, and we collected a lot of data, demographical data, data on concomitant diseases, allergies. Also, patients filled out different questionnaires, as it is listed here. We measured range of motion of joints, then strength of the hand in comparison also to the unoperated hand. We took X-rays so that we measured some parameters in X-rays. So we really collected a lot of data. Outcome measures were patient satisfaction, function, and complications. Here I will present just some of the results of 116 cases that were analyzed. 99 were female and 17 were male. As it is usually in other studies, this ratio, gender ratio, then average age was 58.5 years. You can see the age distribution on the lower graph. As I mentioned, people were really satisfied with the clinical results. There was very high rate of overall patient satisfaction, with 86% of patients who were very satisfied and satisfied. They had good range of motion, much less pain than before the operation, and also they told us that rehabilitation really took 6 to 12 months. When we measured the parameters in X-rays, we found out that the average interposition space height in X-rays was 1.9 millimeters. This is the same as in published studies where they report about 2 millimeters of this space height. This is where we know that this fibrous tissue forms in the space where scaffold was inserted. We only had one foreign body tissue reaction. Some other studies report on more, but clinically we only identified one. 4 reoperations were necessary for pain mostly, and in X-rays of these patients there was osteolysis in X-rays. These were all female patients. In 2 cases, spacer, it means RegJoint, was removed and tendon interposition was done. In 2 cases, arthrodesis was performed. After this checkup of the whole series, we planned another 3 reoperations, but not for problems with the RegJoint implant, but because of instability of the joint. Different studies report different percentages of reoperations necessary. In the study made by Matila, 13% of patients needed reoperation because of osteolysis and reaction to the implant. Kennedy, on the other side, reported of 0% of reoperations. We had only 3.4, but as you can see, we really have a much larger series than other studies. Why these percentages are different might be because indications for operations with RegJoint were different in the other 2 studies in comparison to our. But also there might be that there were differences in operative technique, because several years ago there was not so much stress on the fact that the operation really has to be performed in this non-press fit manner, which we really followed from the very beginning. I checked this with my colleagues, with everyone who was operating on patients with this material, and from the beginning we were aware that there should be enough space for the implant. So non-press fit technique was performed throughout the period when we were using RegJoint. So then we concentrated more on this osteolysis, and we found out when we went through all these X-rays of our series, when we checked the X-rays in our system, which were taken at the time of previous checkups, and then everyone had a new X-ray, and we found out that it was present in 68% of our patients. Surprisingly, we found out that it appeared as early as 1 month after the operation. Literature reports that it can become visible some report 3 months after the operation, some even 6 to 12 months after the operation. But in our series, we noticed also some other interesting feature. The osteolysis did not progress after 12 months. Somehow this area of osteolysis even became more dense. Clinically, in our series, it was not important. It did not cause clinical problems to patients. As you can see clearly in this X-ray, cancellous bone is affected with cortical bone preserved. on each side. And the variable volumes of cancellous bone were affected. In some cases, just a little bit, in other cases, more pronounced, like here. The average bone resorption height in X-ray was higher at the base of the first metacarpal bone in comparison to trapezium. Then we tried to find out what might be the reason, which data might be statistically significantly correlated when we compare osteolysis and other data. So statistically significant correlation was present only between the site of resection and the site of osteolysis, and no statistically significant correlation between osteolysis and other factors. The theory, which is accepted now about the cause of this osteolysis, is that it is caused by activation of immune system by faster than normal degradation of polylactide scaffold. This degradation is affected by compression of the scaffold if the patient is operated with the press fit technique, which means that the scaffold is compressed, or if too early vigorous physiotherapy is started, which was also not in our case because they were immobilized for 2 to 4 weeks. But the factor which we cannot control is the fact that there are normally present high forces across the joint present. Another interesting fact is also that in rheumatoid arthritis patients who are on immunosuppressive medicines, osteolysis was not present. On the other side also, these rheumatoid arthritis patients are low demand patients, and also other joints where RegJoint is used in, for example, in feet, this problem with osteolysis is not present. There is another question also which came to our mind, and it is, what is the importance of local osteopenia at the base of the first metacarpal bone and trapezium in patients with early stages of thumb carpometacarpal joint osteoarthritis? If I conclude about this retrospective study, it is definitely the largest published follow-up series. Functional results are very good. Patient satisfaction rate is high. We have very low rate of reoperations, but the osteolysis of adjacent bones is high. It has early onset. It is self-limiting. It is still not completely clear if there is any clinical importance or not. It might be if it is very pronounced, and if we, for some reason, then would now decide on implanting prosthesis, then we could not put the prosthesis well into such a bone. But the question which really bothered us was which patient will develop it. Even analyzing all this data we collected, we were not able to answer to this question. This is why we then went to the lab. First, we took tissue samples out when we did reoperations in those 4 cases that I mentioned, and then also in cases where which we are operating now, those 3 where we have to stabilize the joint, and we take this tissue which is there in between the remnants of the RegJoint and the soft tissues. We take it out and we send it for pathological analysis. As you can see in these photos from pathology department, fibrous tissue is there with inflammatory cells and foreign body cells, and also the remnants of bioresorbable material are there. This is what we knew from literature, but we now really saw what's really going on. But then we went a step further. Through some other project, we established contact with the biotechnological company Infinite in Maribor, which is a startup deriving from Institute Jožef Stefan, which is the main research institution in Slovenia. They are developing platforms for study of osteolysis. And when I saw what they are doing, they were asking for some tissue samples from our department, and we started to exchange information on what we are doing. We have this problem with this large series. And I said, oh, yeah, this is what we are doing at the lab. And then we found this common interest, and we put the data together, and then we started really quite a big project, and we believe it is important not just to find out how is this interaction going on between RegJoint and the tissue, but also much wider, as you will see on these following slides. So at this stage now we are studying interactions between the implant, our RegJoint implant, and stem cells differentiated into bone tissue. We take fat tissue by liposuction from the patients when we perform at the department liposuction and then lipofilling. Then some of this fat remains, and with the patient's consent, we send it to the lab, and in 3 to 4 days they are able to make osteoblasts from these stem cells deriving from the fat tissue. And this is our platform for further research. So in this experiment, we are studying the interactions between the implant and stem cells. We evaluate the adhesion, proliferation, differentiation of stem cells into bone tissue. Then they monitor and predict the long-term development of inflammatory responses as a result of these interactions. What is already known, what is already existing in this field is that generic osteoplatform is there. Digital twin of early osteolysis evolution is also there. And these two enable to find out what is the long-term hazard of various implant materials for population in general. This is known, but we went one step further. We want to develop personalized version of platforms, which means that for a specific patient, we will be able to diagnose if this person would develop osteolysis in the next, let's say, 6 to 12 months. So before implanting a certain material, not just RegJoint, any material, we would be able to diagnose if this material would cause osteolysis or not. So personalized digital twin, not just general digital twin of this early osteolysis evolution related to any selected implant material is now developed. I mean, it's in the process of developing, so that we would be able to personalize, to do this personalized prediction of the evolution of potential osteolysis events in a certain patient. In vitro research now means that the mesenchymal stem cells are isolated from fat tissue, they are cultivated and and differentiated into osteogenic line. Then in vitro, they observe cellular system responses to the implant. We obtained one scaffold. They degraded it into very, very small particles. In this way, we somehow saved on time, because we are not looking at the response, which might take, several months until it is degraded, but it was made into small particles, and these small particles of polylactide are in contact with the cells, and then advanced analysis are performed. Towards the development of a digital twin, this means that all this data is collected from our studies, from our retrospective study and from these microscopes, so that we study now this long-term inflammatory response progression. I will share with you a few of these first photographs that were taken under the microscope. Also, some videos are available so that we can follow in time what's going on with cells, what's going on in this osteogenic platform that we developed. In this picture, you can see that there is increased production of the collagen network. This white material, you see, this is a collagen network. Small red dots, this is the RegJoint material, polylactide, which was made into very, very small particles. Green represents cell membrane and blue tubulin structures. In this next picture, you can see unusual morphology after cell division. Same green cell membranes. Look, there is more of this red material here all around. Then this one is also interesting. You can see that the material, the red dots, is internalized within cells. And also the material which is in the matrix outside of the cells, it's surrounded by collagen network. We are now really observing this new biology. We can literally see what's going on with these cells within this system. In this picture, you can see a cell, how it looks before division and then after division, when there is multinucleation visible in the daughter cells. Several nuclei appear. And also, again, small red dots, this is the polylactide. So if I conclude, operating on the first carpometacarpal joint osteoarthritis is with the RegJoint implant is a clinically very successful procedure. Postoperative complications are the same as in other published studies. I today mostly concentrated on osteolysis, which is most pronounced and also mentioned in other articles. But for example, paresthesias on the dorsal side of the thumb. This is in a few cases mostly transitional sensation, as in every other study. And in our series of patients, there was very low percentage of reoperations. This is also important finding. The research I mentioned at the end, it really connects our clinical practice and our observations in our clinical practice and the lab science. And it is definitely enhanced by the most advanced technologies for predicting of potential osteolysis events. Thank you very much for your attention. Greetings from Maribor.
Wow, that's wonderful. Thank you, Jerneja. Please leave the dia show still there if someone wants to ask. We thank you a lot for the very intriguing and fascinating presentation. Thank you. And then we would like to have lots of questions, right? And anything and everything, hopefully regarding this topic. So then I would just say in Zoom, you can raise your hand, and if there's not too many people asking at the same time, you can just open your microphone and ask away. Perfect. Catherine, go ahead.
Hi, good evening, and thank you very much for this really nice speech. In a case of the new prosthesis, the touch prosthesis, do you perform also this for the arthrosis of the CMC1 joint?
Not yet. We went for training and we are waiting that our hospital
Yes.
starts buying prosthesis.
Yes, because of since there are the prosthesis, I do much more prosthesis than doing the epping procedures. Because at the moment the prosthesis it's very good and the rehabilitation is much shorter than after a normal operation with RegJoint. I do
Yes,
also.
in recent years, also in several articles, there are, um, let's say, guidelines or instructions on how to approach the patient with the first carpometacarpal joint arthrosis, so that we don't operate everyone with the same method, but we first decide on the stage of the disease, how severe the problems are, and then we offer the patient the operation which is most suitable for his stage of the disease. And it is good that we have several options
Yes.
available. Yeah, so that we offer the appropriate technique to the patient which we have.
Thank you.
Can we have more questions?
I would have a few questions. Dr. Vidmar, you in your first slides, you mentioned that you have also used RegJoint for STT joint. How many of those cases you have had, and what kind of results you have achieved with those?
I think there were only 2 cases done in this way, but in that location, no osteolosis was present.
Then I would have another question. I understood that you are preparing preparing a scientific publication of these results. Can you share with us a little bit more about the time frame when we can expect to see these in a scientific peer-reviewed journal?
We already presented results of our study at the last year FESH meeting in Helsinki. This was the first presentation in European area of our results. And then in November 2025, also our results were presented at the International Hand and Wrist Congress in Dubai. So now the next target is to present these retrospective results in one article that we are writing. This will be the next one, but then we are really concentrating now on this biotechnological research. It's not just about the RegJoint. It started with the RegJoint and our these developments, but now it grew into really a big project with which we are trying to develop the diagnostic tool for any material which might cause osteolysis after the implantation. Orthopedic surgeons in our hospital also are doing some similar research with this company. after they implant the hip prosthesis. They also sometimes have this these problems with osteolysis, and they already found out some new cell events, some new events at the subcellular level. Why and how this process is started. So we are putting hopes into this research so that we will be able to offer the diagnostic tool within a few years. Let's say we think that it will take 4 to 5 years to develop this digital twins to this level that it will be possible to offer personalized diagnosis to the patient before implantation of a certain material.
Okay, that's very interesting and very important, because that's something which have been asked from us several times, that is there any way or opportunity to test at least those patients who are who can expect to have some tissue problems. Is there any means to test them before implanting anything? So
Yeah.
it's very valuable if you are able to create and develop this kind of tool for the surgeons. Then any other questions?
At this next level of research, we will go back to our series of patients and we'll invite some with the osteolysis and some without. So we'll create these two groups, and we'll take the fat tissue and we'll try to reproduce the process in the lab to test this hypothesis, to see if the tissue from the osteolysis group will really also develop this reaction in the lab, and the other group not. This is our next plan.
Okay, that's very good to know, and that's very valuable as well, because that would have been my third question, whether whether you are planning to do something like that. Okay.
Also, these reoperations were very invaluable. When it is not much reported on what the surgeon sees when you open the joint after the RegJoint was there for a certain amount of time. What's there inside? What you see? How these surfaces are. And we also, whenever we open the joint like that, we take samples of soft tissues, we take samples of adjacent bones, and our pathologists are now concentrating on really, to describe what's there in these adjacent bones, how the osteolysis is developing, because we are taking RegJoints out at different times after the operation, and we are trying to see what's through this data, what's how the process is developing, to see what's going on.
Okay. Yeah, that will be interesting to hear later on what you find. what kind of findings and conclusions are then later available. And I wish pleasant evening to everyone.